Good evening, everyone, and thank you for joining us today. We know your time is precious, and we're deeply grateful that you're chosen to join us today. Together as a community of parents, caregivers, and advocates, walking a challenging path, a path filled with love, hope, and often really tough questions. Today's webinar focuses on a topic that lies at the very heart of our journey: pain management and palliative care for children with neuroblastoma. These words that can be hard to hear, but they also the potential to bring real relief, guidance, and often comfort for both children and families. This is a deeply personal topic for me. My son, Shir, went through intensive treatments with neuroblastoma. And like many of you, I found myself constantly searching for ways to ease his pain, physically and emotionally. There were moments of deep helplessness, but also moments where the smallest relief, whether from medication or medication adjustment, a gentle hand, or even a well-timed distraction, felt like a gift. I came to understanding that managing pain isn't just about the medicine. It's about presence, understanding, and partnership with compassionate professionals who truly see the children behind the illness from the very beginning of our journey. We're incredibly honored to be joined tonight with Dr. Elisha Waldman, a leading voice in pediatric palliative care. Dr. Waldman is pediatric oncologist and palliative care specialist at Great Ormond Street Hospital in London. His work, and truly his heart, is centered on children with serious illnesses and on families who love them. Dr. Waldman brings not only extraordinary clinic expertise, but also deep compassion and insight into the emotional and ethical complexities families are facing. He has worked alongside many children and parents, and he understands the balance between aggressive treatment and human care, between fighting for a cure and preserving joy, dignity, and comfort. This session is an opportunity to learn, to ask, and to feel a bit more empowered as you navigate a decision that no family ever expect to face. We hope it gives you a new lens through which to see palliative care, not just giving up, but as showing up for your child in the most loving and supportive ways possible. So with great appreciation, it's my pleasure to welcome Dr. Elisha Waldman.
Okay. Thank you so much for having me, Tuena, and thank you everybody who's listening to this for giving me your time. As Anat said, I know this is not an easy topic at first blush, although I hope, and really the goal of this talk is I hope I change what some of your perceptions may be. And in some respects, this talk is almost more focused on those who are not actually attending to listen to it, which I'm sure there are people, just to name it, palliative care people are into just naming the problems. I'm sure there are people who looked at the title and felt, oh, this isn't for me, or oh, no, not today. And so, my hope is that somehow this talk trickles back to a lot of those people because a lot of this is going to be about dispelling myths. Let me advance. I'm not going to linger long on my own background, but I just want to share a couple of essential points of my background that sort of to validate why I'm sitting here talking about this. I trained in medicine actually after an undergraduate degree in religious studies when I thought I was actually going to go into academic religion and took a weird turn into medicine. I trained in New York in pediatrics first, and then in pediatric hematology and oncology at Memorial Sloan Kettering Cancer Center. So I was just saying I was actually at MSK back in the early days of the antibody therapies. So I have intimate knowledge of what that looks like and the history of neuroblastoma treatment. I worked as a pediatric oncologist for a number of years, in particular in Jerusalem, where I was in charge of the care of children with sarcomas and neuroblastomas for the Greater Jerusalem area and Central Palestinian Authority. At some point in my working time in Israel, I realized that I was getting interested in this topic of palliative care. It's a long story. I sort of backed into it before I realized what it actually was. I left for Boston for a couple years, trained in pediatric palliative care and hospice at Boston Children's Hospital. And since then, and that was about 13, 14 years ago, since then I have not practiced primary oncology anymore, but have focused on palliative care, although often dealing with oncologic patients. First, for several years at Columbia Medical Center in New York, and then for 6 years, I was at Lurie Children's Hospital, Chicago, where I was the division head for pediatric palliative care. And now for 2 years, I'm here at Great Ormond Street Hospital in London as part of the palliative care team. So that's by way of my qualifications and how I ended up sitting here. I'm sure that story sounded crazy, and if there are questions at the end, I can address how someone ends up in such a zigzaggy career. Great Ormond Street Hospital, for those who are unfamiliar with it, is fairly old, founded in 1852. You can't tell, but they haven't updated the rooms all that much since then. It is the largest children's medical research center in Europe and one of the earliest pediatric palliative care teams to ever come into existence anywhere. So there's a very storied and rich history around pediatric palliative care here. We are now a 40-plus member multidisciplinary team. We cover not just Great Ormond Street, but we cover the greater London area. And yes, I've been here almost 2 years and still figuring out how to readjust to the NHS, having worked for years in the US and Israeli healthcare systems. Again, I can come back to that later if people have questions. But what I want to talk about this evening, as I alluded to with the opening, is to maybe dispel some myths, maybe pull back the cover. I'm going to use a lot of mixed metaphors here. I'm going to pull back the curtains on what pediatric palliative care really is. And that's actually a fitting metaphor because the term palliate actually comes from the Latin word for to cloak or to cover something. And in fact, what we'd rather do this evening is uncover. So I'm going to start with this, and I hope this resonates internationally, as I'm sure there are people watching this in different countries. I hope Reese's peanut butter cups are an international phenomenon. For those who are not familiar, it's a candy with chocolate surrounding peanut butter in the middle. And my goal this evening is to convince you all that chocolate and peanut butter belong together. If some of you may remember, I'm going to date myself, but there was an ad campaign for Reese's peanut butter cups when I was younger, where it was always someone had peanut butter and someone had chocolate, and they bumped into each other, and someone said, "Hey, you got your peanut butter and my chocolate," and "No, you got your chocolate and my peanut butter." And of course, the end resolution is, "Oh my goodness, these are amazing together." And I think that's a fitting metaphor for palliative care in the context of neuroblastoma management. I worry that people see it as, I've got my chocolate here, I've got my antibody therapies, and I've got my chemotherapy, and you've got your peanut butter over there, and I'm not ready for peanut butter yet. And these two things don't go together. And so let's talk about why perhaps they do. So first and foremost is to ask the question of what's the problem, right? Why do people think chocolate over here and peanut butter over here? Why are there perhaps fewer people attending this talk this evening than might otherwise have been expected if I was talking about, for example, a cutting-edge new therapy? Well, the problem is, you'll see I'm going to rely on a lot of paintings. We're going to be with Picasso for the next few minutes in a couple of paintings. I think the problem is that as Picasso portrayed here, this painting is science and charity. I think people think of these things as not going together, right? Or being sequential, or somehow operating in parallel, but not is a joined unit, right? You've got your science and your somber approach, and then you've got your charity, or, I mean, I actually think palliative care, I hope, has an enormous amount of science in it. I've published quite a bit. We're an evidence-based field, but people think that somehow these two don't go together. And it's a lecture for another time. I think this painting is fascinating because it sort of captures, while it's called science and charity, and both are at the bedside, there's a real sense in this picture of opposition and needing to choose between the two. And I think a lot of that has to do with um, preconceived notions about palliative care. Again, just to name it, people think palliative care is end of life care, and death and giving up. Or at best, sometimes people use this phrase parallel planning. Oh, we should be thinking about what if. And I hope that what I'm going to get to in a moment is talking about what palliative care really is and where that end of life fits in. So there are preconceived notions. And unfortunately, I think our healthcare system all too often reinforces those preconceived notions. It's not just the public and parents and patients who might have ingested those preconceived notions. It's some of our colleagues, right? Where I hear often from colleagues, no, you shouldn't come see my patient yet because they're not ready for that yet. And I don't really understand that. And I hope by the time I'm done with this talk, you may also look at this and hear that sort of thing and say, what do you mean they're not ready for it yet? Everybody should have this. Because that is part of my argument that the standard of care in 2025 for neuroblastoma, regardless of stage or risk or where you are, the standard of care should be involvement of a pediatric palliative care team. And if you are not getting that, you are not getting the best care possible. It's a stark statement. This is really what I should hope people are thinking about when they think about pediatric palliative care, right? It's a somewhat happier image. So I'm going to linger on this one for a few minutes, because I want to talk about what pediatric palliative care is. And I'm going to focus a whole bunch on that now before I get to, okay, so what about neuroblastoma? I'm going to share with you the definition that I use when I talk to my colleagues and when I meet new patients, because I think it's important. And listen carefully, because it's a carefully crafted definition. I stole it from people much smarter than me. Pediatric palliative care is a multidisciplinary approach to providing support for children and families facing serious, often potentially life-limiting illness, regardless of stage or prognosis. All right, I'm going to repeat that because there are very important components to that. It's a multidisciplinary approach. It is not just a doctor walking in the room. Of all the fields of medicine, I truly believe that palliative care operates in the most level, egalitarian playing field of any field of medicine. It means physicians, it means nurses, it means psychosocial support, social workers, psychologists, chaplains, child life, music therapy, many more that I could go on to name. That's often the central group. All right. If I walk into the room alone, just me, that's one leg of a stool that's missing two other legs. And we know what happens when you sit on a stool with just one leg there. It's a multidisciplinary approach to providing support for children and families, right? There's always that question, who's our patient? My patient is everyone in the room. It's the child, it's the family, it's the grandparents, it's the siblings. And sometimes that's challenging. There's a funny dynamic, right? Sometimes it's not so straightforward. There are different needs. Each of those characters I just named may be in a different place in their own journey of coping. or where their goals are or where their hopes are. And part of our task and part of hopefully our skill set in palliative care is gathering all of those differing needs and metabolizing it into something that's usable. So we're multidisciplinary, providing support for children and families, regardless of stage or prognosis. We are not end-of-life care. And I will say this to families up front when I meet them, unless I'm meeting them truly for end-of-life care, which happens very rarely, frankly. It is true that end-of-life falls into our wheelhouse. I am an expert in end-of-life care. I do think palliative care providers know how to handle end of life at a level of expertise that is beyond what most other providers have. If I were to draw a Venn diagram, that is this circle here, tiny little circle, if I'm on the screen. And what I really do with most of my care is an enormous circle around that. Very little of my work is about end of life. In fact, I'm going to describe for you in a moment what it is I do in a room. And hopefully what I'll show you through that is that actually, if I meet a family at end of life, I don't have a whole lot to offer. I have some symptom management tips I can offer. But really, my traction and my ability to provide support, no matter what happens, increases alongside of how much time I've spent with and how well I get to know a family. So yeah, I was going to flip forward. That does mean that sometimes I was going to use this Picasso. It's a little more somber. Sometimes it's this Picasso, usually this Picasso. We do both. What that means is, and I also want to pause for a moment to note, I am part of the only pediatric subspecialty, I think, that has to deliver a 15-minute introduction on what it is that I do, right? No cardiologist has to spend 15 minutes explaining what a cardiologist does. Only palliative care has to do this, which is fine, but our task is spreading this education. What that whole long definition means is I do different things for different families at different times. I often think of it as a thermostat where I get dialed up or down, and what I'm doing may change depending on what's happening. We do a lot of complex symptom management. So we'll come back to that in a few minutes, right? Pain, certainly potentially a part of neuroblastoma management. But we also manage symptoms, really, as I tell parents and patients, anything that's bothering you, I want to know about. Nausea, constipation, anxiety, depression, sleeping issues, general management issues. I don't like swallowing liquids. I only want to swallow pills. I just spent half a day, I kid you not, dealing with that with a patient here. That is a valid issue that we should be addressing as a medical team. And we don't know that that's an issue unless we ask and get our heads around how do we make this journey as good as possible, not even as least bad as possible. We should be making it as good as possible. So we do complex symptom management. We do help navigate decision making, right? Surgeries, feeding tubes, experimental therapies, further rounds of chemotherapy. And I want to be really clear. My job is not to dissuade families from doing anything. In fact, you might be shocked to know the number of times I find myself consulting with families and turning around to my medical colleagues and saying, actually, this family's goals of care are completely aligned with another round of chemotherapy and seeing what happens with that. Sometimes my colleagues are frustrated by that because they think I'm going to go in the room and dissuade families from doing things. And that is not at all what palliative care is about. It is about understanding who a child and family are, what their hopes are, what their fears are, what their values are, and what their goals are. And making sure that our healthcare offerings align with those goals. And I don't know if that sounds simple or complex to people listening to this, but the number of times that I see family and patient goals misaligned with what is happening medically is shocking. Our medical system tends to get on a railroad track and head forward and shoot first and ask questions later. And that is not a good way to provide healthcare. That's actually, as some would put it, that's providing sick care. That's being responsive to problems as they arise. Healthcare means finding out who is this child at the center of the story and making sure that we knit our healthcare system around those needs. So how do we do this? I'm not going to sort of go into this too much in detail. Normally, this is for my trainees, this is like an hour-long talk about just how to do this. But I do want to give you a taster and a sense of what happens when we're in the room. When I go, my team goes, because it's not just me, when our team goes to meet a child and a family, our consult follows usually similar contours. We start with the following. We know the medical story. We've read the chart. We've talked to the medical teams. Where we'd like to start is, who is your child? Right? What's a good day? What's a bad day? What does your child enjoy doing when they are not here? I could get off track here talking about the responses I see. Usually, within the first 30 seconds, and families recognize within the first 30 seconds, they've entered into a different domain of healthcare. The number of times I've had parents say to me, no one has ever asked me that before, is also heartbreaking and shocking. So we talk about who is your child. We talk about, with everything going on, this may sound like a silly question, but what are you hoping for? Right now, that sounds silly because I'm sitting here at Great Ormond Street Hospital. On one level, every family here is hoping for exactly the same thing, right? That they wake up tomorrow morning and I'm just a bad dream. This whole thing is just a bad dream. But when you learn how to do the palliative care conversation, you get to the next level down. And sometimes the main hope is, I just want to get through these treatments and cure this and finish it. Sometimes the hopes are more nuanced, right? I just don't want to be alone. I want to make this through with my family intact. I don't want my child to suffer. I want to make it to my child's bar mitzvah, wedding, school graduation, what have you. So we talk about hopes. We talk about fears. With everything going on, what is your biggest fear? Sometimes it's death. And then we talk about death when that gets named. A lot of times it's not death. Also, it depends on when we come into the story, right? Sometimes it's just that I'm starting antibody therapy next week and I've read all these things and I'm afraid it's going to hurt, right? And finally, we talk about, with everything going on, I'm wondering where you usually find your support to make it through day by day, and how is that working for you now? We talk about supports. We talk about spiritual care. How does spirituality fit? It's a big interest of mine personally. How does spirituality fit into your support network? How is that working for you now? Do you have the supports you need at home and in the community? These are really important things. Everything that I just described, which by the way, again, like I basically spent a year of intensive fellowship training learning how to ask those questions. That's what fellowship is. All of that I take and I distill into what we call goals of care. That's the stuff that we take to help guide medical management in a way that aligns with what's important to a family. Now, obviously, it's more complex than that, right? We have these conversations. Sometimes it's a big conversation. Sometimes we have these conversations in bits and bobs over time. Sometimes we return to parts of these conversations over time. For families who I know for weeks or months or years, there are families who I've cared for many years. I told you it's not just about end of life. And goals change over time, right? It's like everything in life. So this is what we do. By the way, I want to emphasize, because I've said several times, it's regardless of stage or prognosis, what we do is critical for survivorship as well. And we have studies to back this up. We have real data. No human being, child or adult, passes through the crucible of serious illness and emerges unscathed. Period. Nobody. No patient and no loved one passes through unscathed. You cannot. And we know that how patients do afterwards when they survive, or how families do afterwards, even if their child has passed away. We know that the experience of illness, how well symptoms were managed, how well they feel they were listened to, how well their spiritual and psychosocial needs were attended to, all of those things severely and deeply impact how people cope in the long run. And it's actually a blessing that we're able to think about that in pediatric oncology now, right? It's not just thinking about survivorship or how to make it through the illness. It's thinking about how to make it through the illness better, right? That's why I said earlier, it's not just about making the treatment as little bad as possible, as least bad as possible. It's how to make it as good as possible. So where does this fit in with neuroblastoma? Let me ground this away from Picasso for a moment. And then we're going to bring this back to questions, because I hope I'm already starting to get some ideas into your minds. I hope I've already said things that may be new for you. Neuroblastoma, to my mind, is an ideal illness for palliative care. It is the perfect chocolate to my peanut butter, right? When I've just described to you all the various forms that my peanut butter can take. Yeah, it can be sticky sometimes. Sometimes you got to drink a little something to get it out of the bag. I keep going with the metaphor. But it is the perfect complement to the chocolate that is the management of neuroblastoma. Neuroblastoma, I think more than any other cancer that I can think of, I think has at least as many, if not more modalities of treatment. Surgery, chemotherapy, targeted therapies, radiation, immunotherapy, differentiation therapy, stem cell transplantation. You've even got CAR T cells popping up on here now, right? I mean, and like much of medicine, it's a blessing and a curse at the same time. Sometimes our knowledge is getting out ahead of us. I would offer, for example, each of these stages, each of these interventions offers not just risks, not just potential for bad side effects or for unpleasantness, but offers an opportunity for us, especially including a palliative care team, to think about how to do this better. Antibodies are a perfect example, and I'm bringing it back to that because I have my own personal experience. I was telling Anat before we started talking, I remember as a fellow a million years ago when antibody therapy was just starting, sitting up late into the night, giving pushes of opioids to patients who were in extreme pain, getting the first antibody therapies because we didn't know. We didn't realize that, oh, we should have a protocol for this. Oh, we should think about starting gabapentin 3 days beforehand. Oh, we should be starting a PCA hours beforehand. All the things that we know how to do now, right? So for example, in my last position in Chicago, our palliative care team met every single patient getting neuroblastoma treatment at the stage of antibody treatment because we took over for pain therapy. And we made sure that those patients got their antibodies pain-free. And we got to know the patients. And then we knew the patients and the patients knew us so that no matter what happened for the rest of the therapy, we had a relationship. And that conversation that I just conveyed, my peanut butter, that whole long, what are you hoping for? What are you worried about? Where do you get your support? I could return to that over and over time. So that if things went well down the road, but let's say a kid was having anxiety issues or a patient was having issues with nausea with some of their end of their therapy treatments, the families knew. There's those nice palliative care doctors we got to know. Can we ask them about the anxiety and the nausea? And we would come back and help. And then watch them go off to the survivorship clinic and sometimes even jump to the survivorship clinic to help with pain management or whatever symptom management there. And likewise, yes, for the patients where it didn't go well in the end, those families didn't have to meet us in the final moments where it's ridiculous to ask, what are you hoping for and what are you worried about? Right? I can't ask those questions when I'm meeting a family 5 minutes before the end. It's too late for a good palliative care consult then. But if I've known them for months, years, it's still a sad conversation, but it's a much easier conversation to sit with a family and a patient and say, I'm remembering last year when you talked to me about how X was the most important thing to you. And I'm worried about how we keep X at the center of what we're doing now. Right? We are here for whatever happens, happy and sad, difficult or easy. But the earlier we're involved, the more traction we're able to have. I want to share with you, actually, I was just talking to he won't mind because he's spoken publicly about this already, a former mentee of mine who is now a pediatric palliative care physician, I'm proud to say. I've known him since he was a pediatric resident, and he underwent a stem cell transplantation last fall for a bone marrow issue. And he's fine now. He's 8 months out. And I was talking to him last week, and I also heard him speak publicly about this, which is why I'm comfortable sharing it. And he said to me, and he went to a major center that I've already named in this talk. He said, when I was getting ready for the treatment, before it even started, I demanded a palliative care consultation. And he said the oncologist thought I was crazy. They said, you're going to be in for a month. You're going to be fine. We expect you to do well. It's too early. And he said, I demand it. I want them here as an extra layer of support, no matter what. And he got it. And he said, you know what? In the end, he said he didn't need them very much, although he had some issues with nausea. And he said they were exactly the right people, even though he knew which medications to ask for. And he was grateful they were there. And now he doesn't need them. And he says himself, if God forbid something happens in the future and I need them, now I know them and they know me. But I don't think he'll ever need them. I hope he never needs them. And they were an extra layer of support for his experience. But he did something that I want to get across here, which is he demanded it. Right? I want to touch back to again what I said earlier. Right? Having palliative care is part of your child's management, is part of getting the highest quality of care in 2025. You should demand it. Right? Palliative care, as I'm mixing my metaphors again, right? It's often the elephant in the room. And like the story of the blind man with the elephant, right? The one where someone grabs the tail and says, oh no, it's a hairy hose. And someone says, oh no, the beast is a long, hard, sharp stick. And someone says, no, no, it's a big flappy cloth, right? Palliative care can be different things for you and your family, depending on where you are and what you need. Right? Some days it may just be pain control. Some days it may be spiritual support. Some days it might be end of life. Some days it may be anxiety because I'm heading off to survivorship clinic and I'm being told the rest of my life is going to be great. And that actually scares me. We can be anything. The only thing we can't do is if we're not in the picture, we can't be any of these things. Right? We need to be in there. And so I'm going to end and open up for questions. I got my timing down. By the way, it's rare. I'm a preacher's kid. Normally, I talk on and on and on with a captive audience. This was pretty good. I want to land where I started with Reese's peanut butter cups, right? Too often, I think people misunderstand. Actually, I think people misunderstand what the chocolate is in the story and what the peanut butter is in the story. and are sure that they cannot go together. And the fact is, I think that when you come to really understand what palliative care can offer in all its different forms, whether it's the trunk or the ear or the tusk, I told you I would mix my metaphors. When you really understand what palliative care might be, it makes complete sense, not just to welcome it in and to mix it with your chocolate, but to demand it. As one of my trainees, actually the one who first introduced me to this metaphor, one of my trainees once told me, once you introduce palliative care for what it really is, it's like free ice cream. Who would say no to it? Right? I mean, once you really get sort of the more holistic, broader 2025 understanding. Now, I will say, as my final caveat, now that I've presented it as, this wonderful thing that everyone should want in their story, palliative care provision, the ability of palliative care to provide its services varies from center to center. Right? I mentioned at the beginning that here at Great Ormond Street, we are a 40+ person multidisciplinary team. Even with that, we cannot meet the needs of every patient in this hospital across all the different forms of illness here. And we do run into situations where we have to triage and we have to pick and choose. And sometimes we have to rely on just giving advice to our primary colleagues. And that's all the more true at centers that might have smaller services. But I hope that one of the things I give to people here is some ammunition to go back to your centers and say, why don't we have more of this? And I have to say that when you look at the literature around integration of pediatric palliative care into different conditions and different clinics, the most robust literature we have is for integrating pediatric palliative care into oncology outpatient clinics. There is a lot of literature out there showing that it's feasible, that it's acceptable, that it works. There's some great models out there. I can call out some of my colleagues. Children's Hospital of Atlanta, for example, has an amazing integrated clinic. Catherine Brock, I'll even name check people. She's wonderful and she's really put together a great program there. Boston Children's has outreach. We do it at Lurie Children's of Chicago. We started a program there where a day a week we had someone in the clinic. If you don't have it, raise the question. How can we do better here? Because the data is out there that it's possible and that patients do better, regardless of stage or prognosis. You should get to know your team early. The earlier, the better. And in fact, right, the later, the worse. That's what makes it hard, and that's where we end up with these misconceptions. So I'm going to wrap it up there and open this up for questions and conversation, because I could keep going down a number of rabbit holes here, but I hope I provided sort of a brief overview and pointed out really what I said about antibodies could be said about any of those intervention stages. So I think I'm going to stop sharing and move over to questions, even though I so very much want to leave the Reese's Peanut Butter Cup picture up because it feels just right. But I will come out of that and we can see if there are people have questions. There's no open questions at the moment, but I'm happy. I don't see anything. I've locked my phone on purpose so that this wouldn't happen. Of course. It was I'm going to give you a moment if anyone has questions. I can certainly add more texture to some of the things that I've commented on here if there are no questions. But I'll see if things pop up. In the meanwhile, since nothing is popping up, again, I'll return to the antibody question because I think that's it's such to me an obvious, concrete example of where palliative care can and often does get involved. And it's a great sort of inflection point in the course of a child's treatment because it's not sort of a decision-making point, right? I mean, your child is going to get these antibodies because this gives the best chance for treatment. Like you are on a protocol and you're heading there with the hope for cure. And I think that's a really good place for palliative care to get involved because we don't have to have the hard, terrible conversations. We're just getting to know who you are and who your child is at that point. I sort of alluded to earlier that in many settings, what the movement has been is to integrate palliative care and invite palliative care to create protocols for pain management. So often that involves a really rational process of thinking about different pain management modalities, so different pain pathways, right? You've got your opioid receptor, you've got your NMDA receptors, you've got your gabapentinoids, right? So gabapentin or pregabalin. Um, You've got your sort of lower tech interventions like paracetamol and ibuprofen, which may or may not be relevant depending on sort of where the patient is and what their body may be able to tolerate. And so in many places, palliative care teams will come in when invited and work together in partnership with the neuroblastoma management team to create a protocol. There are a number of different protocols out there. Sometimes, so here at Great Ormond Street, for example, we'll start gabapentin a couple days before the antibodies to let it get going. We'll get a PCA up and running in the morning. We'll make sure that there's already opioids on board. And we have a protocol in place for not just the infusion and demand doses, but for rapid escalation when necessary. In Chicago, we did the same thing. Chicago, we also would use ketamine if we were running into issues with increasing pain demands. Usually within the first, once you've got one round of antibodies in, you've got a sense of who that child is. You've kind of got which extra touches, like ketamine, for example, tend to work for this child. And subsequent rounds tend to go, the first one sometimes requires some adjustment and some agility from us through the morning. By the second round, they're much smoother. And it really makes an enormous difference, right? I mean, I'm sure I'm preaching to the choir here. It's the difference between a child getting up in the morning screaming and yelling and freaking out that they don't want to go to the hospital because they know they're about to have a horrible experience that's going to hurt and they're going to feel nauseous. And then they start vomiting when they get in the car because they're already making themselves wound up. It's the difference between that and a child who comes in happy. I mean, I've seen it. I wouldn't have believed it myself if I hadn't experienced it myself. A kid who comes in happy and happy to see us, the palliative care team, and says, oh, get that medicine started. And we empower them, right? We empower them to tell us which things work. And here's your button to press. And they know, I mean, it's a heavy commitment from the team. But in Chicago, we would say to them, and they know here as well. Chicago, I think of because I was sort of more directly involved as the head of the team. They know if you are not feeling well, someone from our team is going to be there in under 10 minutes, usually 2 minutes. But we promise you, under 10 minutes, we are going to be at your bedside and we're going to be responsive. And it makes all the difference in the world. And I really think not just for subsequent rounds where it really turns what could be a horrible traumatic event of a days, it turns it into a much more pleasant experience. That resonates down the road into survivorship, right? The kids who handle their therapy, who are met with good pain management and who are able to come in and feel good about those days are also kids who get out of treatment in the end, who are cured, and who are better equipped because they're not traumatized in the same way. So yeah, I just want to emphasize that. There is a question that popped up here. Thank you. Thank you for your thank you. I'm going to read this because I don't think everyone can see the questions. As a bereaved neuroblastoma parent, so first of all, I want to say thank you for coming to this talk as a bereaved neuroblastoma parent and now patient advocate. What can we do as a collective to better advocate and influence change in policy, like a charter for best practice for pediatric palliative oncology care? Yeah, that is the question, right? What can you do? And I think part of the answer is the seeds are being planted. I mean, this is sort of why I mentioned my background in oncology, because I can now look back on 30 years of practice and I can see the changes, right? Whereas I want to be careful because I don't want to, I'm grateful for every institution and everyone who ever trained me. But instead of a time and a place where palliative care really was thought to be end of life care, and no, you're not allowed in until the very bloody end. And we didn't really have a voice at major conferences like ASCO and ASPHO, right? The big pediatric and PSYOP, the big European group, pediatric oncology group. There was no representation when I started. I mean, frankly, when I started, pediatric palliative care was barely a thing. The sort of the big seminal article came out when I was a general pediatric trainee. I shouldn't say that's not totally fair. The modern age of evidence-based, I think, really is a later phenomenon. There are people who've been doing this, as I mentioned, for a long time. Now when you go to conferences like ASCO and ASPHO, there are committees on integrating palliative care. There are papers, there are talks. I mean, it's a thing. I think it still requires agitation, and I use the word agitation quite deliberately, right? Because it's almost more than advocacy. I think it requires a degree of demand, and that's why I used the term demand earlier. It's beyond advocacy. It's looking at the evidence, and the evidence is out there. Those articles are out there. It's looking at those and going to your providers, your oncologists, and your hospital leadership, right? Because change does not happen unless leadership is convinced, and saying to them, look at this. This is becoming the standard of care. Right. And it is a leadership issue because hospital leadership, unfortunately, what this boils down to in the end is dollars, right? I mean, it feels really gross to say that, but hospital leadership needs to understand that they need to pay for palliative care providers to be able to provide this scope of treatment. And really what it hinges on is making them understand that this is the standard of care. And that argument works. Right? Because I've been in that position. I've described my zigzaggy career, and especially in the U.S. where a lot of this is competition driven. You go to hospitals and say, actually, I shouldn't pick on the U.S. I literally had this conversation this morning here at Great Ormond Street, where we are advocating our team wants more money for psychosocial members, and I said to leadership, you are missing the boat. We are a major center. Great Ormond Street is on a pedestal in the UK. It's a revered institution. And I said to them, you are at risk of losing that place because you're going to rest on your laurels and you're going to miss out while the rest of the institutions move past us, because the standard of care, the best care possible now, demands that I be in the room together with a psychologist, a social worker, a chaplain. We have to have those people if we want to look around at our colleagues around the world and say, yes, we are providing the best care possible. It's not just about being a member of PSYOP or, God, I just blanked on the name of the US, COG. Been out of the US for too long. It's not just about being a member of the biggest cutting edge trials. It's about having all the components that go around it, right? I used to argue at Lurie's. I'm going to keep going with my argument. Sorry, I told you I'm a preacher's kid. In Chicago, all the buses in the city of Chicago have these huge advertisements on the side for Lurie Children's Hospital, which is truly an amazing hospital. And it's all these kids, with different conditions, and it shows, kids who've gotten heart transplants and I went to a leadership meeting once and I said, you are making a terrible mistake here because there should be a bus that has a picture of members of our team on it or a patient of ours. And you don't do it because you're afraid that the slogan next to it is going to read Pediatric Palliative Care at Lurie Children's Hospital for when we failed and your child's going to die. I said, and that's your mistake. Because what the slogan should be is Pediatric Palliative Care at Lurie Children's Hospital because we want the best care every day for your child, no matter what is happening, even when they survive their illness. It's a long tagline. It needs some work. That's why I'm not in marketing and my wife is, right? But that's the idea. Hospital leadership needs to understand that this is just as important as having the antibodies and having the cutting edge therapies and having the research and being able to say our researchers are publishing in the New England Journal. You also want to be able to say, we're doing cutting edge work in palliative care and showing that the antibodies, that all these treatments, that all the cutting edge things that are coming, that they can be given in a better way that ensures better experiences for the children and their families, that makes it go down easier. I'm still waiting for someone to do the trial. It's going to be hard in the pediatric world, but in the adult world, someone needs to do the trial showing that when palliative care is introduced early in experimental studies, that patients actually stick with the trial for longer. I truly believe that that is true, but I believe it in my heart and we need to prove it. That when you're getting the better symptom management, you do better. By the way, for those not familiar, I will jump to an adult analogy. There was a now classic study in about 2011 or 12 from the Harvard system where I trained subsequently in adult non-small cell lung cancer, which there have been some advances in the last couple of years, but it was largely incurable. And in Boston, they did a study where they took adult patients with non-small cell lung cancer, same exact profile patients, same exact oncologic therapy. The only difference was in one group, they mandated regular meetings with the palliative care team. Okay? What do you think happened? There's one surprise to what happened. So perhaps unsurprisingly, all the patients who were seeing palliative care reported better symptom management. I will also say that all the family members and survivors, family members who survived, if the patient died, the surviving family members also reported better long-term coping. So less long-term psychological and emotional issues. The real surprise that came out of that study was the patients who were seeing palliative care routinely lived longer, right? The joke among palliative care providers at the time was, if you could put us into a syringe, we'd be worth $1 billion, right? Unfortunately, you can't. So I think there are real arguments to be made here to leadership, and you should make them to your oncology teams, that palliative care isn't a nice to have, it's a must have, right? And that requires some agitation. Hi, you got me all wound up. No more questions. There are more questions? I only see the one. I appreciate anyone who's even tolerated now I'm becoming sort of my messianic zeal about palliative care. My hope is, because I'm going to hand this back for final words, I think. My hope really is, if you take one thing from this talk, right, it's Reese's peanut butter cups. My hope is, first of all, what palliative care provider opens his talk with Reese's peanut butter cups? That in itself, on a meta level, should dispel certain myths about palliative care providers. But my one take home that I hope people take away is that they really do go together. They're not just okay together, they're better together.
Thank you, Elisha, for your fascinating and eye-opening presentation. I'm sure we all have a lot to do in this matter, and I'm sure that all of us that were here and all of us that will hear this later on will probably, the first thing they're going to do is to demand palliative care as part of the treatment plan. Thank you so much for being here today with us. Next webinar is BCC, Beat Childhood Cancer Update, Clinical Trial Update, DFMO, immunotherapy with chemotherapy, and everything else that you want to know. So it's in July 7th, so I hope to see you all with us. Thank you.